Hello, everyone. This is Dr. Anup Kanodia and Dr. Millhon I'm from KanodiaMD, and Judd's from Dr. Millhon's from Ohio Health, and this is just about heart health overall. And there's been a lot of stuff on the news about COVID and heart health, but just over heart health in general too. I'll introduce myself, and then we'll have Dr. Millhon introduce himself. Most people should know me on here, but just in case you don't, I am a medical doctor. Did my born and raised up in Akron, college and the med school Akron, residency at Mayo Clinic, and then fellowship at Harvard, and then worked at OSU for 4 years. And now we have a private practice here in Columbus, Ohio for about 8 years or so, with a passion for functional medicine. Dr. Millhon, your video was there and now your video is gone. Oh, there it is.
Hi.
So do you want to introduce yourself, please?
Sure. My name's Judson Millhon. I'm born and raised in Columbus, Ohio, and I'm a cardiologist that used to practice clinical and interventional cardiology. I was in private practice for about 15 years, and in 2009 became employed by Ohio Health. And most cardiologists in Columbus are working for some hospital system in town. So I'm an employed Ohio Health physician, but about 2012, I started having back issues and ended up with 5 surgeries. So my interventional cardiology work ended. And for the past few years, I'm certainly working full-time in cardiology, but doing mostly outpatient cardiology.
Cool. And so February is Heart Month, and again with COVID being here, so I thought to bring on a cardiologist, so that obviously he's got much more knowledge than a family doc like me. So I thought that we'll ask him some questions, and then we'll go through some of your questions, your Q&As too. So my first question to you, I think on the mind of probably a lot of Americans, is that I guess when people say heart health, what are we talking about?
Well, hopefully we're talking about prevention of cardiovascular disease. So that's the first step. And since cardiovascular disease is the #1 killer of men and women in this country and worldwide, I think we should focus on how do we avoid becoming a cardiovascular patient. So that involves health, wellness, and prevention, lifestyle, all of those things. And I think the month of February being the Heart Healthy month, remind us not to focus on the treatment of cardiovascular disease, which I did in the first 25 years of my career. I mean, I just opened blocked arteries. Now I want to spend the next 25 years helping people prevent themselves from ending up in the hospital for a cardiovascular procedure. So that's health, wellness, prevention, and that's what I think this month should be focused on.
Awesome. And I think that's what we also look at from a functional medicine perspective. Same thing is that how do we work together? And one of the things is that Dr. Millhon is greatly trained in the whole conventional side, plus some circulation side, and you'll hear about this today, where the functional medicine side is a great collaborator for sometimes when all the severe things are ruled out. Now, what else can we do if we want to go down to the side of treatment, but also from the side of prevention? So one of the things that we're hearing about is COVID-19 and how it affects the heart. So I did see one study out of Germany that took a whole bunch of people, took every patient with COVID, did all the testing, including echoes, etc. And I saw about 70% of people had some type of cardiovascular change. Now, is that reproducible in America? Who knows? So I guess my question is, in your clinic, let's say pre-COVID, how many people would you would see because of a cold or flu, having heart symptoms, etc., on an average day or like average month?
Yeah, so every viral illness and every viral pathogen can affect the heart. And we've known that, we've studied it, we've confirmed it for many years by myocardial biopsy. So you can see somebody who had the flu or a viral illness, they have heart muscle dysfunction, you biopsy their heart, you see that viral pathogen. That's what we know viruses can do to the heart muscle. Now, COVID comes along, and we always expected that virus could do the same thing, and it does. What we don't have is a lot of studies that have confirmed by myocardial biopsy COVID infection. But we have studies that have shown people that have had normal hearts, they've had COVID, and then their hearts are weak. So there is that inference that this virus affects heart muscle. Now, I have seen, in 1 year since COVID came out, a lot of people, a higher percentage that have had cardiac symptoms worried about COVID. So prior to COVID, I could correlate a viral illness with a cardiac problem probably 5% of every patient who had symptoms. Without the biopsy that's available, to confirm the COVID thing, I would say that that's doubled. I would say there's at least 10% of people that I see who are COVID positive that I feel by non-invasive testing, COVID has affected their heart function.
Wow. So that's good to know that the COVID may be doubling to some degree the viral component for the heart, and the heart may be affected by that.
I think so, but
yeah,
that's
perfect.
not been proven.
Of course. No, I mean, this is the back of a napkin by an expert cardiologist, one that's been in the field for a long time. Probably you have seen many more championships than me. I'm a Cleveland Browns fan, and I'm a Cleveland fan, but but let's go based on now. Let's look at this a different way. Let's look at how many people do you normally see heart-related that would have cold flu-like symptoms in the average month?
Well, I hope to not see anyone with
Of
just
course.
cold and flu symptoms.
That had heart symptoms. You know what I mean. You know what I mean.
I would hope not to. But I do see a lot of people who have had cold and flu symptoms that have so-called cardiac complaints or cardiac symptoms, right, like chest pain, shortness of breath, palpitations. I saw a lot of those pre-COVID, and I've seen a lot more post-COVID.
So then pre-COVID, so you're seeing a lot more. And are you seeing double, triple, quadruple? How much more are you seeing now?
Oh, I can't give you an objective answer, but I mean, subjectively, it is more than double. More than double. I am seeing young, middle-aged, and elderly patients who are concerned about their symptoms. They're concerned about COVID, and they're wondering, is there a connection?
Got it.
That's what I'm saying.
Yep, perfect. And I'm more of, and Dr. Millhon, you can tell me, but I'm more like just answer questions right in the middle. Or are you better, or do you want to go more with the flow of this and answer questions towards the end?
I'm up for whatever you want to do.
Okay.
I'm not reading every one of these chats.
Of course not. Yep.
I can, but
nope. Don't worry. I'll take care of that.
All right.
So let's continue on this track before we take Michelle's question. There's a couple others. So you're seeing a lot more patients now, and sounds like the major symptoms you're seeing is shortness of breath, palpitations, chest pains. These are the people that got COVID or thought they got COVID, and now they're coming to see a cardiologist. And just so we're on the same page, I'm dropping things now. That's okay. Just because palpitations, that means something different with their heartbeat. So
that's what they feel. They
they
feel something
different with their heartbeat. Okay, and so you do the workup on them. They come in, and after you do your cardiology workup, whatever expert workup you have, tell me what happens. How many of those people would you say is it COVID related?
So all of those symptoms, chest pain, shortness of breath, palpitations, occur in a large proportion of our population, pre-COVID or post-COVID.
Right.
So the workup is not different in either situation. So if I see someone who was COVID positive and I'm seeing, 3 or 4 patients a day who were proven COVID positive patients.
Okay.
They can't see me until they've been quarantined, but they've had all of those symptoms. And when I see them, their biggest concern is, Doc, did the virus hurt my heart?
Okay.
Because as you know, when this whole thing came out, locally here in Columbus, there was a lot of concern about myocarditis, which is the infection caused by a virus that affects the heart muscle. And like I said earlier, every virus can affect the heart muscle, but
Right.
this COVID thing really raised the bar in terms of, canceling sports events and nationwide. So the people who have access to all this information are the people that come in COVID positive, those symptoms, did it hurt my heart? And that's what I see 3-4 times a day.
Okay.
And most of the time, 90% of the time, it turns out that, in my opinion, the COVID virus did not affect their heart muscle function, but I can't tell them that without doing some workup. So I'll usually do, obviously the EKG at the office visit, an echocardiogram, which is an ultrasound of the heart. And sometimes I'll put the patient on a monitor so that objectively, when they feel a palpitation, the monitor will tell me if this is an abnormal heart rhythm.
Okay.
So that workup has, again, occurred more frequently pre-COVID, but it's the same workup regardless.
And so then these people that you're seeing, and the workup you're doing, thank you. How much of those people then, what percentage of them you think is COVID related? Or let me ask it this way. If it is COVID related, what treatments are we having available for them? So like, let's say someone is having, they had COVID, they're having shortness of breath, they're having palpitations or chest pains. But yeah, there may be a correlation to COVID and it's not stress related or something like that. Do we have good treatments or how is that?
So the treatments are the same pre and post COVID. If somebody has, we'll go with palpitations, because usually palpitations occur when there are premature heartbeats, whether from the top chamber, premature atrial contractions, or the bottom chamber, premature ventricular contractions. So if someone has symptomatic palpitations from those benign ectopic beats, the treatment is supportive. The treatment is increased sleep, decreased caffeine, decreased alcohol, increased hydration. Those are the conservative treatments pre or post COVID. If they have shortness of breath and they have an echocardiogram that shows their heart muscle function has been diminished or reduced, that's more of a direct sign that this virus affected the heart, and that means it could be myocarditis, which is the word everybody's talking about nationwide. So if the heart muscle function is reduced, the treatment remains the same pre or post COVID. It's, medical care, medications designed to improve heart function, like beta blockers and ACE inhibitors and diuretics, and just standard medical care for a heart that's weakened.
Got it. So what percent of patients do you think has the shortness of breath, palpitations, chest pain, are you able to help, or that maybe benefit from a functional medicine or integrative medicine approach?
I mean, I want to help them.
Right.
I do, but the workup that I described, if that is so-called benign or normal, or doesn't require cardiology care, that doesn't mean their symptoms are not relevant to them. That doesn't mean their symptoms aren't real. It just means that there should be other options for their care, like the stuff that I just mentioned, or a functional medicine physician, healthcare provider that looks more in depth to the broader picture.
Got it. So this is a good segue that some questions here. Let's knock some of these out. So one of the things is someone asked a question about that, and this is more of, I guess, a cardiology question, but we should ask it. I guess someone has severe blockage and they need a second open heart surgery. And I don't know that's so, but any thoughts on that?
Okay, so you can't remove any blockage in a major artery, whether it's carotid artery or a coronary artery or a leg artery. Those are big blood vessels that generally are like the size of your thumb. And what I did for 25 years, if there was a blockage in a heart artery and it was limiting the blood flow, I would smash it with a balloon and then put a stent in to relieve the constriction. And if I couldn't help that blockage, if it was in a location where a balloon and a stent wouldn't work, then I would refer the patient to my cardiothoracic surgery colleagues who would do a bypass procedure. But a bypass procedure doesn't remove the blockage in that large artery. It just bypasses the blockage. So there's really nothing currently that removes blockage in large arteries. Now there's lifestyle things, there's medications, there's applications that can be used to help stabilize or prevent the progression of blockage. But in those large arteries, there's nothing that reverses that currently.
So, and then Dr. Stephen, I'll give you my answer also. Thank you for that, Dr. Millhon. So this is a great point of how do you prevent a third one? If the surgeon's saying that the second one that's needed, then how do we not have a third one that's needed in the future? And that's this whole prevention side of getting the heart optimized. So why is it that there's a buildup in there? And this is, I think, a good segue about cholesterol for a second, at least from my standpoint, and the buildup of blockages. So we all know that the heart has arteries, and if we think of the arteries as like roads on a street, you know how roads, we get potholes. So then when you get potholes, you got to fill the potholes up. And so what does the liver do? The liver makes pothole solution. So the liver makes cholesterol, it fills the potholes. But it doesn't fill the potholes level, it fills it too high. After it fills it too high, it then can become blocked, or then you then need a bypass or something. So the more that we keep the arteries healthy, the less the body needs to make cholesterol or fill up potholes. And if people want to say, well, what about the coronary calcium scores? So calcium gets deposited on top of the potholes as a way of trying to protect the pothole, but it does increase your risk of heart attacks and strokes. So let's go to the next question. Is that I've heard that COVID can cause pulmonary fibrosis. So I know you're not a lung doctor, but have you seen any of that or heard any of that?
Well, yes. I mean, COVID affects the most common systemic effect of COVID is pulmonary, and it usually causes bilateral pulmonary infiltrates, sort of like a pneumonia, but it's a viral pneumonia. And that raises the pressure in the lung. It raises the pressure in the pulmonary artery. And there is a component of a more coagulable state in all the vasculature, including the lungs, and that can cause small and large clots, which raises the pressure again in the pulmonary artery. And if that's left untreated, it can cause scarring in the lung. And the first step of that is pulmonary artery hypertension, then pulmonary fibrosis. So that's been documented worldwide.
Got it. So thank you for that. Let's ask Cindy's question. It's such a relevant thing. I see this a lot here. Is that Cindy got COVID and she's so tired. So let's assume from a cardiac standpoint, it could be a heart related thing. What things do we think about if someone says they're tired from COVID from a heart standpoint? And then I'll tell you functional medicine wise here.
Yeah, for sure. So anybody that has a viral illness, as I've been saying, that virus can affect the heart muscle, and if it causes an infection, a myocarditis, and it causes a heart muscle dysfunction, if the heart muscle dilates and becomes extremely weak because of the virus, then that's a common cause of shortness of breath and fatigue. So everyone that I see who's had a viral illness and post illness says, oh my gosh, I'm so tired, I'm fatigued. I check their heart, and I check it usually with a history, physical, EKG, and an echo, an ultrasound of the heart. And if that heart muscle by echo is just cranking away, then that person's fatigue is not cardiac related. There are other issues, but it's not cardiac.
Perfect. So what percent of people who have fatigue, and it may be, and again, you see the worst people, but because people have to have COVID, then maybe see the primary care, maybe not, when they come see you directly to see a cardiologist. What percent of people who are tired is because of a heart defect? That
very, very low. I mean, 5%.
Okay, so now Cindy, let me tell you how we approach it from a functional medicine standpoint. So you guys have all probably seen this term called long haulers, right? People that have COVID and then 3 months out, 6 months out, still having symptoms. So there's a couple things. One, that infection can still be in your body. If so, then there are things to raise the immune system to help kill that off, from T cells, natural killer cells, etc. Also, there's things where when people are tired, we find the number one organ that's affected is something called mitochondria or organelle. It's like the energy factory of the body. Or if you think of a car, it's like the engine of a car. So if your mitochondria is not working right, you're many times that you're tired. So, but yes, we see a lot of that here in the office, and it's a very common thing to see. And the same thing also applies to people with a vaccine. If people with a vaccine get tired, etc., the same things are also relevant there. Um, the but Cindy, I do want to tell you that a lot of people have gotten better from the tiredness of COVID. So I think that I've talked a lot about vaccines already. I'm going to skip that question for right now. And we'll come back to that. What I want to talk, I see the next question I have here is this idea that, so from Michelle Vale. So she's a female. She has autoimmunity. She has Hashimoto's disease. And so how does having more than one autoimmune affect COVID heart issues? So if people have autoimmune diseases or more than one, do you see more or less heart symptoms with those people or more or less heart issues?
Not more.
Okay. So, what is interesting, and let's take a segue to here. I just saw a study recently that's saying that I think at least 60%, if not 70% of people who had significant COVID, I think hospitalized COVID, had high blood pressure. So let's take a step back now and saying, what can someone do, or what are some risk factors that we think about for heart that may then make them more susceptible then to getting heart symptoms with COVID?
Well, that's a perfect segue, because if you have an underlying cardiovascular condition and even non-cardiovascular conditions, but if you have hypertension, if you have diabetes, if you have coronary artery disease or any other vascular disease, every study since COVID came out has shown you are at a higher risk of developing severe complications.
Okay, so let's talk about this. So what are some common things? So there's high blood pressure, right? There's high cholesterol. Yes, no, maybe not.
No,
okay.
Every one of those risk factors,
Right.
if is present prior to COVID, increases that person's risk of a worse outcome with COVID.
Right. So then that's
been shown.
Right. So, but I want to talk about these risk factors so people know that it's being a smoker. Is that right? Diabetes.
Correct.
And please help me out here with this list. So please give me other risk factors that we should be thinking about.
Okay. So let's again, my theme so far today is pre-COVID, post-COVID.
Right.
So for what we're going to discuss right now is for both. So since cardiovascular disease is the #1 killer of men and women in the world, the risk factors for that are, first of all, foremost, genetics. We can't, change yet your genetics. Second is smoking. These are in order that heighten your risk for a cardiovascular event. So genetics, smoking, hypertension, diabetes, obesity, high cholesterol, an untreated sleep disorder, and physical inactivity. So if you put all of those things into a package, that package is all of the currently known risk factors for a cardiovascular event. So both pre and post COVID, if you want to reduce your risk of a cardiovascular event, each of those risk factors minus your genetics should be treated to the optimum goal.
Perfect. So let's break this down. I think blood pressure is, we'll come back to blood pressure, we'll come back to cholesterol if needed, but let's talk about obesity or weight. So a simple thing, and the people who are listening or watching or both, write down something called a BMI calculator. And you can go online, type in your height, type in your weight, and they'll tell you. You can type it, I think, depending on which ones is gender also. They'll tell you if you're normal weight, overweight, or obese. That's easy to do. So that will give you a flavor, because I don't know that people realize in this country who's overweight, who's obese, because of, I think, what, 2/3 of the American population is either overweight or obese. So that's one thing. Let's talk about sleep. And again, back of the napkin thing that Dr. Millhon's talking about, sleep apnea, right? So a simple question I ask, and Dr. Millhon, please fill in more, is that, let's say you have a spouse, and the question I ask is, does your spouse have to kick you to breathe? If she has to kick you, if he or she has to kick you to breathe, you may have some type of sleep apnea. Or if you snore so loud enough that there's no breathing for a period of time, you may have sleep apnea. And that would be good to get a sleep study. Dr. Millhon, tell me more if there's any back of the napkin things that people can figure out if they have sleep issues or sleep's part of their going to make them higher risk for illness, etc.
Yes. So 15 years ago, we didn't even really know what sleep disorders were. And everybody uses sleep apnea as the diagnosis of a sleep disorder, but sleep disorder is a huge umbrella of sleep disorders, and sleep apnea is one prong under the umbrella. So we'll use sleep apnea as an example. However, there's a lot of other sleep disturbances, and the key is that all of them, no matter which one you have, all of them result in the same final problem, and that's low oxygen. So if you think about it, if you've had low oxygen levels every night, day after day, year after year, then what does that cause? And we never knew. We never correlated this, but now we do know. We know objectively that low oxygen levels cause every bad thing that can happen to a heart. And I'll just stay with the heart. The low oxygen level can cause the heart to enlarge and weaken. That's the cardiomyopathy. The low oxygen can cause every cardiac arrhythmia, even the benign arrhythmias, like we talked about in the beginning of this, premature atrial contractions, premature ventricular contractions, all the way up to serious arrhythmias like atrial fibrillation, ventricular tachycardia, all from low oxygen. And I'll keep going. Not only heart muscle weakness, not only arrhythmia, but it has been proven that untreated sleep disorders with low oxygen plug up arteries. It increases atherosclerotic burden. I mean, it's a huge deal, and we're just at the tip of the iceberg. But I think if you answer yes to your questions clinically, does your wife have to kick you, or do you snore excessively? The very minimum is just to have an evaluation.
Yep. So I mean, that's one take home from today that I want you guys to do, is that if you guys feel like you're stopping breathing in the middle of the night, talk to your doc or make an appointment, etc. Because it's amazing if someone has sleep apnea and they get that treated, they feel so much better. They say, "Oh my God, my life is so much different." I'm gonna jump to Lisa's point and about the Aura Ring. That has gotten great feedback, and so I do like that a lot, the Aura Ring, and that's more sleep quality stuff, which is, I think, something different for a different topic, but I do like that. Let me talk about, on your list was physical inactivity. Let's talk about that for a second. Are you defining that as exercising or sitting in a sit down job, or how are you defining that? And what things can we do for that part?
Well, yeah, it's a continuum.
Okay.
as you know. So I don't know. This was a buzz term a few years ago that was put out by the American Heart Association that sitting is the new smoking. So people
actually, actually, do you know who coined that term?
no.
Me, my friend.
Oh, great.
At 2011, I coined that term.
Well, that's fantastic. Your term and coining was correct. So it's all a continuum. So sitting is worse than standing, and standing is worse than walking, and walking is worse than, you know, increasing your heart rate with walking more briskly or jogging or running or doing any kind of aerobic exercise that increases your heart rate. And so just like all those other risk factors, immobility, inactivity, lack of aerobic exercise is a key component to increasing your atherosclerotic risk. And so anything on a continuum is better than nothing. So,
Right.
like I
So
said, if you have a standing desk, which I have at work, if you just take 10 minutes to walk up and down the hallway before you sit back down, it's all beneficial.
perfect. So let me give you guys some rule of thumbs, right? That I've seen some data saying your day should not be more than 50% sitting. At least 50% should be standing or moving around on average. Um, let's say that you do have a sitting job. The data is pretty resound that even if you get up out of your chair 2 minutes every half an hour and walk, good data there. Then I'm not even talk about fast walking, just up there. Um, and if you have to have a sit down job, sometimes they even have those pedals underneath the table. You can pedal while you're working. But sitting is a component of all this stuff. Now the physical activity part, I know we have guidelines, and Dr. Millhon, you'll give me yours, but you know, when I think of exercise, I think of sweating, right? If you do a type of exercise and you sweat, that's probably going to help the heart out. The heart's a muscle. It's pure and simple. Don't have to sweat, but that's just a back of the napkin type of thing. One of the things that we find that helps the heart out is something called high intensity interval training, HIIT type of exercises. And one simple one that comes out of the University of McGill is a 20-minute workout. 2 minutes, you may warm up, and then for like the next maybe 10 minutes or so, you do 1 minute fast, 1 minute normal, 1 minute fast, 1 minute normal. And that can be done with walking, with running, bicycling, swimming, anything else you want. 1 minute fast, 1 minute slow. Then when you're done with that, then a couple more minutes like wind down. And that's been really easy to do to help the heart out or help just overall fitness out. And we'll come to more about that. There's more about fitness, but any other on the cardiovascular side of fitness or whatever, that any tips or pointers there?
No, high intensity training is awesome. It has been shown to be beneficial. However, most of my patients aren't ready for that. And your patient population may be slightly different. They may be younger, healthier, more in tune, more ready to, take it to the next level. I'm seeing 75% of my patients that, have trouble walking up a flight of steps because of their morbid obesity and all their comorbid medical conditions. So that's where I start with that continuum of just get up and move and walk, and then we morph into non-weight bearing exercises and all these other things. But yeah, I mean, all of it is beneficial.
Awesome. So next question, and Dr. Millhon, you're doing a great job. So thank you so much. So let's talk. I've got a question. Can people who have had COVID had heart muscle damage recover?
Yes.
Awesome.
So we're gonna say the same thing pre-COVID, post-COVID. Pre-COVID, there were plenty of viruses that affected the heart muscle and made the heart muscle weak. And in those patients with appropriate medical therapy, in a certain percentage, heart muscle can recover back to normal. Now, we don't have any studies currently with COVID-19 for the long-term effects if cardiomyopathy or myocarditis or heart muscle damage was occurred by COVID. We just don't have those studies yet, but we're putting all those patients on the same medical therapy we did with all the other viruses, and we're hoping the same thing occurs for recovery.
Cool. I have another question. And these are not, again, all my questions personally, these are from the audience. Okay, that a patient has palpitations. And that, okay, have palpitations with dialing thyroid hormone already. Okay, so I guess my question is, I'll just paraphrase, I'm not really sure the question is that, I think I know the answer. What you can say is that if people already have palpitations, they get COVID, they may have a higher chance of having maybe worse palpitations afterwards.
Correct.
Yep. So,
but the diagnosis has to be objectively made. What are the palpitations from? Are they from just, the normal heart rhythm that's going faster than what that person should be doing with the level of activity they're experiencing? That can cause palpitations in and of itself. Or are the palpitations from some sort of benign arrhythmia like premature beats, PACs, PVCs, or is the palpitation occurring from another more serious arrhythmia? So you just have to know what you're dealing with, and the only way to know actually is to have that person wear a monitor, and when they feel palpitations, they just press the button, and that button pressing sends the exact rhythm to the prescriber, and then that is a direct correlation to what they're feeling. Then that changes the treatment.
Awesome. So I'll speak about myself, or again, functional medicine, is that we see a lot of people with benign palpitations or stress palpitations. They've seen their cardiologist, meaning they've seen you or someone else, and they said, yep, it's nothing serious. They did the monitor that you did with the easy button that you're talking about, and which is good. Those are the people I see because the severe ones I'm sending your way, of course, and or if they haven't had a workup. So one thing interesting about palpitations, let's take stress out for a second, that it's a benign palpitation, or what your cardiologist would say. It's interesting, the heart is actually a muscle, and I said that before. And Dr. Millhon, do you know a cardiologist named Dr. Stephen Sinatra?
Yes.
Yes. So it's interesting. We've been using his book, and he's a cardiologist out of Yale, or used to be at one point, and he gives heart supplements for palpitations, and we've had great success with the benign ones. And so if someone has palpitations and the workups have been negative, I want to give people that there are options for you to do from both that standpoint and also from a stress standpoint. But moving on to the next question. It's about circulation, and who's better to talk about circulation than a heart doctor? Is there technology or other things we can think about that help circulation out that we don't normally think about in a normal workup from a heart disease standpoint, etc.? And I'm talking about whether PEMF or any other technology that that may be beneficial for circulation.
Yes. Yes. And so the circulation, go ahead.
No, please go ahead.
So the circulation starts with the largest blood vessel coming out of the heart, the aorta. And the aorta is about the size of 3 thumbs.
Okay.
And the aorta comes out of the heart and divides into the arteries that go to all the organs. So it goes up the carotid arteries to the brain. It comes around the arch and divides into the arteries that go to all of our GI tract and all of our abdominal organs. And then it goes and divides into the arteries that go down both of our legs. And so those are the arteries of the body. That is the first part of the circulation, driven by the heart muscle, who's pumping 60 times, a minute. And so the arteries have to get smaller and smaller and smaller to the point where they're providing the circulation to the cells of the body. And that's called a lot of different things. The smallest artery that still has some pumping mechanism to it is called the arteriole. And that's the smallest artery with muscle around it. And that pumping function is called vasomotion. And when we're young and when we're healthy, that smallest artery, called an arteriole, is literally pumping 6 times a minute.
Okay.
And what that pumping mechanism is doing is helping that upstream muscle, the heart, right? Because the heart is pumping 60 times a minute, but it has to pump through all of this conduit that keeps getting smaller and branching out. And so the function of these arterioles when we're young and we're healthy is to propel the blood into the microcirculation,
Okay.
which is our capillary bed, which is very teeny tiny conduits, some of which are the size of a single hair. And that arterial vasomotion is helping propel the blood into the capillaries so that those capillaries can deliver the blood into the tissue in the cells. That's the circulation from the beginning to the end.
Okay.
And there are disease states that impair all of that circulation from beginning to end. Atherosclerosis affects those larger arteries. It also affects the smaller arteries. It affects the function or the vasomotion that becomes impaired as we age. And so there are other disease states that do the same thing. But the bottom line is, even the healthiest person, if they get to a certain point, the vasomotion slows up, and therefore the flow below that in our capillary stream clogs up. And what happens is the red blood cells actually they stick together electromagnetically. It's called the Rouleau phenomenon. And that's just normal aging. So that happens. And then our white blood cells, they have a difficult time getting through that traffic jam, if you will. They also adhere more frequently to the side or the wall of the capillary. So the bottom line is the delivery to our cells is impaired, and the delivery is the red cell, which carries the oxygen, the energy, which provides mitochondria with the energy for their self. It impairs the delivery of the white blood cell that delivers its natural anti-inflammatory response. I call it like the scrubbers, like the Pac-Man. It impairs the delivery of immunity, which can help clear out foreign material, including infection. So that's normal aging. On the back end of that, all of that material needs to be released. It needs to be washed out. And in normal aging, that process slows down just like the delivery slows down. So there are devices that improve the delivery of blood on the intake and the exodus of the metabolic waste on the outtake. And probably the largest broad spectrum medical device is PEMF, pulse
Okay.
electromagnetic frequency, and there are hundreds worldwide companies that deliver PEMF. And 5 years ago, 4.5 years ago, I started studying this, and I looked at different various devices, and there seems to be one in particular that improves the vasomotion and improves the delivery and the release better than others. It's a company that it's called Bmi, and it's been around for 22 years. It's a German company. It's family owned. I was invited to look at it when I had some issues. And for the past 3.5, 4 years, I'm passionate about sharing this technology with people. What I can't do is tell anyone, in person, in a forum, in a in-person, presentation, or even on a Zoom. I cannot tell anyone that this company, this product, is going to cure any disease-specific state. Can't. But I can tell you that the PEMF companies, including this one, who I hold dear to my heart, improves the delivery of the microcirculation and the exodus of the metabolic waste. And that's the final common pathway of circulation. And since I'm a cardiologist, the circulation starts at the heart and ends at the very end. So that's important for good health.
So if I'm hearing right, that technology can also be part of this, and in the Heart Health Month, and in terms of protecting the heart, or after the heart may be strained, circulation is a part of that. And I guess if people want more information about that, if you want to put in your email address in the chat box, someone will get back to you about that, about PMF, etc. Or if you have other questions or something that you want us to get back to you on, please put your email address and your question or something, and we'll try our best to help. I have at least one last question before we wrap up. I know there's a lot more questions here. It's just from Tim Brock. His wife was diagnosed with COVID, was hospitalized for 2 weeks. A week after coming home, her blood pressure went high and continues to go high. Any comments of that for you?
Yeah, COVID affects the circulation by various mechanisms, including the mechanism that controls the lining of our blood vessels. It's a single cell lining called the endothelium. And endothelial dysfunction can occur after all viral illnesses. Again, pre-COVID, post-COVID. This is not unique. So high blood pressure can be affected by that endothelial function, which is in the lining of all arteries, big, medium, and small. The virus itself can create other factors which may increase the blood pressure. Just stress and anxiety alone increases the blood pressure. If you've known you've had a serious infection, that can play a role in the blood pressure. So my recommendation is the treatment is the same, whether you've had a COVID infection or any other infection. If you have high blood pressure, you should try the non-medical management, stress management, exercise, low salt, all the things that have been shown to lower blood pressure. But if that's not adequate, in my opinion, you should treat it like any other person with high blood pressure. And that may be a short-term thing, a medium range thing, or a long-term thing. But that's what we do with anyone, pre or post-COVID.
So Tim, thank you. Tim, let me give you my opinion. And not from a cardiologist's opinion again, but I would say that stress could be a big part of high blood pressure afterwards. But let's say that's not it. Then the heart's working overtime. What does high blood pressure mean? It's pumping extra. It has to pump harder, more pressure. So rather than the tire having 35 units, it's now having 40 or 45 units of pressure in it. So there are supplements that can help, both with killing the infection, working on the immune system, and then also there are things that help the heart out. Again, taking pressure off the heart so it doesn't have to pump as hard. So when I think of that, I think of one is like nitric oxide. It's something that helps with circulation. And again, I like the Dr. Stephen Sinatra's, some of his supplements for the heart muscle, working on that part of it. And there are also blood pressure supplements, etc. There's other things there too. But that's the big picture answer. Let me go to one last question, which I think is relevant. Is that patients that have had the vaccine and may not have, you would have seen, and it's just coming out in Ohio recently here, but have you seen anyone that's gotten the vaccine that's now coming up with cardiac issues that you're now seeing?
I haven't. I mean, I have not objectively seen that, but I've seen patients who've had the vaccine in all two types of vaccines, but I've had them come in with the same symptoms that we talked about in the beginning, chest pain, palpitation, fatigue, So I've not correlated that with any kind of heart muscle damage in the workup that I discussed previously. But, we're early on. I mean, we don't know. I mean,
Yep.
We have to keep studying it.
But good news is you're not having a plethora of people getting the vaccine coming to your office with heart symptoms.
No.
That's good news. So let's do this. We only have a couple of minutes left. Is there any parting words that that you want to give the audience?
My only suggestion is, even though this pandemic has created so much anxiety for the world, our global planet, all the way down to all of us individually, including myself, I just want people to understand, cardiovascular disease is still the #1 killer. And that is something that all the risk factors we talked about, all 7, 8 of them, all of those, if any one is present in any one of us left untreated or left untreated to the goal, increases your risk of having a cardiovascular event. So do your best, no one's perfect, to just try to minimize your cardiovascular risk. This is February, it's Heart Month, and that's my final parting words.
And what Dr. Millhon's saying is very relevant. And the reason is there's study after study showing, I think one might be the Inner Heart study, that 90% of heart attacks and strokes can be prevented. That by doing these things. And so I see one last question for Julie there. And it's how do you spell the circulation method? It's called nitric oxide. NITRIC space oxide, OXIDE. So we'll end with, so thank you, Dr. Millhon, for coming on and answering all these questions. I know that there's probably more questions here on the chat box. What I'm going to try to do is answer them and give that to my team to see if they can respond to you guys, or maybe do a Q&A or something, send an email out, or post on Facebook or something, some of the answers that we didn't get to. People are interested. Please sign up for the newsletter or get on the website, etc. We'll be doing more webinars in the future on different topics, etc. I appreciate everyone coming. I think we had like 95 people, if not more, I don't think I even know 95 people. Maybe I do, maybe I don't, not sure. But thank you for your time, Dr. Millhon.
Sure, I enjoyed it.
Have a good day, everyone.
See ya.